Welcome to Healthcare for All's annual educational conference, and then we'll follow that with a member meeting. Thank you all for coming. You might want to turn chairs around, and I don't know if I'm too loud. Maybe I need to be a little bit calmer. But we will be talking with a panel of experts on lowering drug prices as our educational conference today. We'll follow that with a conversation from our lobbyist, Lonnie Johns-Brown, about the legislative agenda for the 2024, what we're going to be asking you to participate in. And then we'll follow that with a member meeting. So let me welcome everyone. We are live here in Horizon House, and we are participating in this Zoom meeting today from the lands of the Coast Salish people. Please take a minute to acknowledge the peoples in the lands where you are joining us from today. We acknowledge homelands and traditional territories of indigenous peoples who have been here since time immemorial. As we talk today about lowering drug prices and asking large corporations not to take too much, to accept a fair and reasonable profit to maintain their lives, we should take a lesson from indigenous peoples who took care of their land. They took what they needed and left the land to grow and to prosper to what we're taking advantage of today. So before we start the panel, I've asked one of our board members, Cello Echeverria, to give you a few ideas about how you can support us during this upcoming year. Cello?
Hi, everyone, in reality and virtual. It's so, just on a other note, it's so interesting. I've been working with Healthcare for All 2 years, and this is the first time because of the pandemic. Can you hear me now? Is that better? Okay, sorry. Okay, sorry about that. I just wanted to mention that I've been working with Healthcare for All for 2 years, and this is the first time I think that I've met many of you ever in person because I started during the pandemic. Why I work with Healthcare for All Washington. Healthcare for All Washington not only has a very effective lobbying arm that has been very successful in pushing our legislative agenda through with the support of senators like Senator Keiser, who has definitely guided and helped us in this over the many, many years of Healthcare for All Washington. It also, me personally as a volunteer, it gives me access to a level of expertise with for example, pharmacists, doctors, Chris, our vice president, other doctors, Sherry, who's one of the early advocates for single payer healthcare and is a font of knowledge about the history of single payer in Washington state and nationally, and David Loud from Vasara, who is also another font of knowledge about ACO REACH and the horrors of the privatization of healthcare in the United States. So when you volunteer and when you work with this organization, not only are you pushing for something, that hopefully will benefit all of the residents of Washington state, you also personally are getting the chance to really get a deep education into the, as Sherry calls it, the health industrial complex. Please support us. And with that, I'd like to sign off to Senator Keiser and Ronnie, who is hiding.
But Cello, we want to tell people how they can donate.
Oh, shoot, I forgot that. I forgot to tell you how to donate. Okay, so there's 2 ways you can donate. Sid and I are sitting over under our banner, Healthcare for All, nobody in, everybody out. The other way around. I'm dyslexic. So you can come over there. We have our laptop set up. We can either accept checks or we can just register you online, or you can go online to our website. In our homepage, there's a donate button on the upper right-hand corner. And please do admire our brand new website, which we've finally managed to get up with the help of our comms team, which I'm a member of. And please do donate. It's pretty seamless. It's pretty effortless.
And what we're asking people to do this year is to make monthly donations. In the past, or even now, you can make a one-time donation, and we're asking you to do that for if you haven't made a donation in the past year, and many of you already have. So thank you for that. But if you haven't, a one-time donation would be, really important to us. But what we'd like to focus on and ask you to do today is to consider making a monthly donation. We have brought along a lot of swag. If you make a monthly donation, we'd like you to take a couple of either a t-shirt or a umbrella. Don't open it up inside, that's bad luck. No, an umbrella or a scarf. So take two if you can make a monthly donation. And if you're making a one-time donation, at least take one of these things. We've got a lot we'd love to share with you, and it helps spread the word. The umbrellas can actually be used even in the summer. We went to a demonstration for Medicare's anniversary, and we all had these umbrellas to keep the sun off. So they are not just for rain. They can be used all year round. So thank you. So welcome Senator Keiser, and Gabriel Levitt is joining us from New York City, and Dana Brown is joining us from the other Washington. And let me take a few minutes to introduce them. Hi. Oh, no. Senator Keiser represents the 33rd District of Washington. She's joined or was elected to the House of Representatives in 1995 when we were all young children, including you, and then moved to the Senate in 2001 and has been a healthcare champion for years. As a retired pharmacist, it's been a joy to connect with her over lowering drug prices during the year. But she's been an advocate and a leader in our state for the Affordable Care Act being implemented effectively here, and for long-term care and family and medical leave. And so we're honored to have you here. Then Dana Brown, who's joining us from Washington, D.C. I don't see her pictures up here. Can we see her? Is the healthcare director with the Democracy Collaborative. You have gotten information about them in emails over the past few weeks. I hope we haven't sent you too many emails. She focuses on health and healthcare systems, and especially the pharmaceutical sector. She's an author of a book, Medicine for All. And I should have mentioned that you too have a new book. We'll do that in 1 minute. But she's the author of a book about the public case, or the case for public pharmaceutical industry. She's written in national magazines, and Dana has actually appeared with Senator Keiser on other panels in the past. She holds a BA from Cornell University, an MA from Universidad del Salvador in Argentina, and is currently, or maybe you have finished, working on a master's in public health. And our fourth participant, I'm a participant too, is Gabriel Levitt, who is the chair of the board of directors of an organization called Prescription Justice. Gabe actually co-founded an organization called Pharmacy Checker that enables people to purchase or import drugs for their personal use. And we'll be working with his or pulling his enthusiasm for those areas, as well as a number of other areas. He's been active internationally as well. So we will be talking not just about importing individual prescription drugs, but actually importing some of the policies from other countries that enable consumers, enable patients to get these lower prescription drug prices. So we have several different areas that we're going to pull on Gabe's expertise and enthusiasm. So before we get started with the questions, I've asked Senator Keiser to give us, talk about your new book, mention that you have a new book that you have some copies of with you today, and that and what your legislative agenda is for the next upcoming year.
Well, first of all, can you hear me? You need me to speak closer? Is it on now? Okay. First of all, thanks to Healthcare for all the work you've done, for all the years you've been working on these issues. So thank you so much. It's so good to see you in person again. It's been a long time since the pandemic's made us all virtual. And we're back in real life in the legislature as well as of this year. And that's been a terrific thing. Thank you, Ronnie, for putting this terrific group of panel folks from Washington, D.C. and all over the world. It's great. And from my perspective, the last few years, I've drilled down and focused on prescription drugs as really a very big cost driver for so many people. We were focused on hospital costs for several years as well, but to be honest, the hospital cabal that we have outwitted me, but I know how to deal with pharma a little bit. And it's not easy to deal with pharma either, the big prescription drug lobbying team that is mobilized for every bill that we propose. But nevertheless, we've gotten a few things done. So I just want to remind you that we passed the all-payer claims database in 2014, then the drug transparency law in 2016. In 2020, we were able to cap the out-of-pocket cost for insulin. We did it at $100 back then. This session, we put it into, because we thought the federal government was going to take care of it, but they didn't. Anyway, so we did pass another bill this session to make a $35 out-of-pocket cap permanent for insulin. And then in the other big thing that we have, and it's right on our doorstep now, is that we passed the Prescription Drug Affordability Board in 2021, and the board has been appointed. They'll have their first meeting this month, and
Yesterday.
they already had it. You're on. So, you know, also former Representative Eileen Cody has been appointed to the PDAB board, which is really important because this is going to be important work for the PDAB board. And why it's important is because this organization will be able to decide on a list of drugs that it wants to do an affordability review with. And then once they decide that the price of that drug is extremely too costly, set an upper payment limit on what we will pay for that drug. Now, this is being sort of tested in the state of Colorado because they got started about 2 years ahead of us. And Colorado just put out their first list of drugs that they're going to be giving an affordability review and setting an upper payment limit for. And it has started. What pharma does, as many of us in this world know, is they adopt disease groups and they fund them. And then those disease groups become a spokesperson for their particular disease and advocates, don't do it to us because you're going to kill us, because you're going to take away our very necessary drugs. And they are very heartfelt and they have true concerns with their diseases. But they're leading the pack in Colorado right now with the cystic fibrosis, organization, cystic fibrosis, gets a lot of funding. The one organization that doesn't get much funding from pharmaceutical companies is, by the way, multiple sclerosis. So I look at the MS drugs, which are extremely expensive, as a lodestar of what we need to get going with. So anyway, they're going to be putting that piece together, and you're going to need to help them make sure that they don't get attacked routinely and regularly by the different disease groups that are in the pocket of the pharmaceutical industries. And you'd be surprised how many individual groups are taking those dollars. And they do have a mission, they have a cause, but they also become compromised with that. So that's kind of the lay of the land currently. Going into the 2024 session, I have two bills that I do intend to propose. One is called Alex Bill, because Minnesota passed it last session. Minnesota just got a change in control of their legislature, so they got a lot of good stuff done. And Alex Bill is one, and it requires that our drugstores have an emergency supply of insulin on hand for individuals who are unable to pay. And there's a process where they fill out a form for the healthcare authority to get an emergency-free 30-day supply of insulin. And then the drugstore would be reimbursed by the drug manufacturer, either reimbursed or they'd replace the supply. So that's Alex Bill that I'll be dropping here in about a month. And the other bill that I'm proposing for the 2024 session has to put a cost cap on EpiPens. EpiPens, as you know, are epinephrine, and they're used for allergic reactions. And children especially are vulnerable, and EpiPens are a delivery system that really works for them. But our schools require that if you have a child with an allergy, you have to have an EpiPen on hand at the school as well as with the child when they're out and about. EpiPens are really expensive. As you may know, they had a huge, huge cost increase. So for two pens that do not last forever, it's $300. And so you have to put one in the school and one on the kid every 6 months. That's a $1,200 bill every year. And so we're going to try and put a cost cap on EpiPens as well. At least we'll give it a good college try and see how far we can get. I'd like to put just, because the pack comes for two pens, $60 out-of-pocket cap for EpiPens. So that will be the other bill I'll be proposing. There's one other bill that's still in our Senate Rules Committee, and that is Senate Joint Resolution 8202, and that's a constitutional amendment to guarantee reproductive freedom in our Constitution. So hopefully we can get some progress with that as well. So with that, I'm just going to say this about the book. As you've seen in Congress these days, not much, if anything, is going to get done in our federal legislative body with the outrageous situation in the House and really the thin majority in the Senate. Very little of consequence except budgets gets through. So it's up to state legislatures to make progress, in my opinion, at this point, especially state legislatures like ours and Minnesota's and California's, where we have a pretty good solid majority that can enact really important legislation for the tens of millions of people that live in our states. I saw that during the pandemic that we were seeing a lot of young women, especially, and people of color who had come into the legislature get completely discouraged and frustrated and upset with the legislative process, which is arcane and difficult, I'll grant you. So I wrote a book, and it's basically Getting Elected is the Easy Part is the title, and it's on Amazon. It's published by the Washington State University Press. And I brought a few copies here if people want a signed copy. And it's for advocates or new lawmakers or for reporters or even new lobbyists who don't know really what the process is and what's going on. It's a mystery. The legislative process is arcane. There are a lot of unwritten rules, and it's kind of a primer or a guidebook for anybody with a lot of personal observations and quite a bit of research. talking about the different issues that come before us. So anyway, that's my pitch, and I'm going to just be here for after we talk to, if you want to purchase a book, they're $20.
Well, thank you. Thank you. Dana,
I'm
our
happy
first
to let you go
question,
first
you've
if
really
you want to
started
talk
this off
about.
with an answer.
Are you going to
I'm
talk about
wondering, and I could pull in
state-based
opinions from Gabe and Dana.
state-based negotiations?
Can we really negotiate?
Both.
We want to hear,
prescription prices.
about
Well,
both.
you know what?
Medicare's have an impact on individual states. Can individual states have an effect on Medicare? I think there are several ways that these actions can go. You've talked about what we're doing here in Washington State. So Dana or Gabe, you want to jump in with what's going on in your neighborhoods?
I'll just chime in quickly to say, first, I want to thank Washington Healthcare for All, and I want to thank Ronnie and also Robbie Stern. And I wanted to let you know that I know firsthand that they do have lobbying reach, and it extends beyond the state. And I'll save that for maybe some other time. But I just wanted to say, kind of from a aerial view, most of you know that in 2003, there was something called the Medicare Prescription Drug Improvement and Modernization Act, which, look, it wasn't great because drug prices have shot up like crazy since then. But then again, let's just take perspective. Medicare and older Americans did not have a pharmacy benefit. And so we got Part D. And then the problem is we got the non-interference clause as part of that, which basically, because of the lobbying of pharma, and there's a lot of that, wrote, a lot of us activists say that this was so clear-cut. Pharma working with Billy Towson, who was the chair of the House Ways and Means Committee, who went off and got a job with pharma for $2 million a year after that act was wrapped up. So the non-interference clause said, government, you cannot negotiate drug prices. I'm sorry, you can't do it. We have to pay for these drugs, but you can't negotiate. Let's go quickly to 2009 and the Affordable Care Act. We could have done something then, but the Obama administration had its eye on its prize, which was getting something across the finish line. So they were going to do drug price negotiations and drug importation. But in order to get pharma's buy-in, they said, okay, we won't do that if you do this. So that didn't happen. Flash forward to 2022. And let me tell you, if I understand the law correctly, and I hope Dana can help us here, I'm extremely happy about the Inflation Reduction Act passing. It's a step in the right direction, but they actually didn't remove the non-interference clause. They created an exception, which allows us to negotiate a small number of drugs, increasing moving forward, but not enough. And with that, that's my aerial view on what went down.
Thank you, Gabe.
Yeah, I think I'll also jump in with some really high level stuff because, well, first and foremost, the details of the Inflation Reduction Act are not my specialty, but also I think most of what I work on is about changing the balance of power that I think led us to the point we're in right now, where, stepping back for a second, I think the question is, right, is it possible to negotiate drug prices? Well, theoretically, yes, right? And even in practice, yes, the US government can negotiate drug prices successfully. We have examples of that. So for instance, the federal government negotiates drug prices on behalf of the Veterans Health Administration very, very effectively, right? The VHA pays the lowest drug prices in general across the market, across all groups all different kinds of drugs, chemical and biologic, right? So theoretically possible, yes. We have legislatively gotten ourselves backed into a corner over many years. And while I think it is important that the federal government has now been empowered to negotiate the price of a small number of drugs, we will spend a lot of money in that process and ultimately may not see the kinds of returns that we'd like. So I guess what I do want to offer in a hopeful sense is that I think there are ways we can start to take back the power at the state level in particular that help really shift our negotiating, help give us leverage at the negotiating table. So Senator Keiser may have heard me say this before. One of the reasons I'm such a big proponent of the public sector, be that at the state level, at the level of a city, or at the level of the federal government, getting into the business of manufacturing drugs or doing the R&D, developing new medications and bringing them to the market fully in the public sector is because it fundamentally changes the balance of power. Right now, Big Pharma is sort of the only game in town. They can threaten to not do R&D. They can threaten to take drugs off the market. They can threaten to, not sell us things if they don't get to garner the monopoly prices that they're used to. But as soon as there is actual competition, then that argument kind of fades away. And we've seen that in practice. Countries like Brazil and Thailand, where they do maintain both research and development and manufacturing capacity in the public sector, when new expensive drugs come to market, as early in the AIDS epidemic, when the first antiretrovirals were coming onto the market, those countries couldn't afford to pay the monopoly prices that Big Pharma demanded. And they said, okay, well, we're going to need to negotiate a discount. Otherwise, we can't treat our population. And Big Pharma said, oh, no, we're not, we can't do that. And they said, no problem. We'll just issue a compulsory license and manufacture them ourselves because we have that capacity. And suddenly they were able to negotiate much, much better prices. So I think, my full answer to the question is long-term, we need to start taking back that power. And I think we can talk about several different strategies for doing that. And those strategies then help us realize a lot of goals that we have in terms of access to medicine and access to healthcare more broadly.
And could I just add that California has taken a couple of big steps forward with this idea of public procurement or direct manufacturing. And we have a Me Too law in our state so that we can go along with whatever California ends up doing. So we're already in place in statute. If California begins to, and they are trying to become a manufacturer or a contract for a manufacturer for generic insulin. And if that happens, we can Me Too that and get the product in Washington state as well. So there are some local state level efforts underway for public production and procurement, because one other thing, we were able to do a public procurement of mifepristone, that's the abortion drug. And we had the Department of Corrections, which has a pharmacy license, purchase it directly from the manufacturer. We got a deep discount. This pill normally costs about $72 a piece, and we got it for about more than 1/3 less than that. And that's because we were using the power of state purchasing. So that's another approach.
And so the answer to the question is, yes, we can. As is steal from another politician, but the Washington state especially has been taking the lead, not just in mifepristone, but in eliminating hepatitis C. Our governor pushed us and enabled us to come up with a unique purchasing plan, and other states are doing the same. That really is vodka. I was joking earlier, but so other states like Colorado, Maine, Maryland, Minnesota, New Hampshire, and Oregon, our next door neighbor, are working on these boards to help make that happen. And Senator Keiser, you've really moved us to the next question, which is actually number 3 on my list, but you really brought up the issue on public manufacturing. And Dana is our expert. And I was wondering if you can talk to us about what are the best steps, what you actually published a toolkit for states. What are the best steps for us to participate in public manufacturing or that reality?
Sure. Thanks so much for that question. And again, Senator Keiser has already partially answered that, which is that your state is already starting to step up. And I think looking to do things like work with the state of California, right? Purchasing the publicly produced insulin, naloxone, and other drugs that they plan to bring to the market is fantastic. I think once states start to cooperate in that way, we're starting to build a public interest market for medicines that, again, pushes back against that solely profit motivated market for medicine that most of us live in currently. There are other states that already do some public production, particularly of vaccines and other biologic drugs. The state of Massachusetts, through the university system, produces vaccines and biologics at a publicly owned company called Mass Biologics. I think that's another area, right, where states can be reaching out and making connections and saying, would it be helpful if we procured some of those publicly produced medicines? Does that help bring your state more revenue to then invest in developing and producing more medicine in the public sector? So I think setting up advanced purchase agreements, like we do in the existing market for medicines, but doing it with a public interest eye, I think that really helps, again, build this public power that we need to get so many other things we want, like transparency in drug pricing, right? And I think it also starts to set the priorities in a different way. What are the medications that are most important to public health, and not just those that are most profitable for drug makers to make? So I think speaking with other states that are starting to dip their toe into this is really important. And also, thinking about the specific human capital and capacity in the state of Washington. If Washington is going to begin to produce medications or medical devices in the future, is it chemical drugs? Is it biologics? Do you focus on devices because other states are producing the insulin, but they need the injectors, right? Can we begin to get into agreements whereby, you produce this, I produce that, and we trade with one another, and we're just bypassing big pharma? I think all of that is imminently possible. Yeah, it costs money, it takes time, but it requires you guys in the room to talk to folks like Senator Keiser and others and say, we really need this, and this is a pragmatic solution for our state. And ideally, right, over time, it actually helps bring down health costs for all of us. I'll leave it at that for the moment. I don't want to say too much. We could talk about this for days, though.
So thank you for adding that, Dana. And we have talked about the barriers that pharmaceutical manufacturers put up. We need to be chipping away at that, and state efforts on whether it's prescription drug affordability boards or the work that California is leading us on. And you mentioned Mass Biologics and Civica RX. There are public manufacturing options. Look at the references we've offered from Dana about that toolkit that states can use. But another big issue that is not just the pharmaceutical manufacturers, there is this hidden, non-transparent, well, that's the definition of hidden, isn't it, system of pharmacy benefit managers, which are not insurance companies. I remember working at Harborview and seeing patients that have been brought in from Alaska or Montana with life-threatening injuries, and the most important thing is getting them out with proper care and proper medicine. And they show me an insurance card that says United Medical or Blue Cross, but there's this little number down in the corner that is a pharmacy benefit manager, and we have very little controls over them. We don't really see them. Even when I'm holding up that insurance card, there's no name that says the pharmacy benefit manager is, a national company like CVS. I don't know. It's just a 6-digit number, and you call and you get spun around. And in fact, at Harborview Medical Center, we had a half a dozen pharmacy technicians that spent their entire workday on hold talking to pharmacy benefit managers, trying to get an answer. So what can we do state-wise? I know the Pharmaceutical Association has identified that issue in Washington State, and I'm sure it's been happening nationally. Gabe, do you want to start off, or Dana start off with that, or?
You know what, Dana, pharmacy benefit managers, while I understand the broad scope and the agony of middlemen on the supply chain, and they just suck up oxygen and don't actually negotiate drug prices. It's not my bailiwick. So if you want to chime in, that would be great.
Sure. Wait, I mean, we can also all just discuss it too. I mean, I'm a bit of a radical here in the sense that I live in Washington, D.C., which is a bad match for my politics, because in D.C. you learn that we can only even talk about things that can be done this legislative session, which in general is nowhere near commensurate with the size of the problems that we deal with as a society. But all that to say, I mean, we don't need PBMs, right? The US existed before PBMs, and we could exist again without them. No other country in the world seems to need them. So I actually think this is a place where, of all of the issues about access to medicines and drug pricing and whatnot, this seems to me like the biggest no-brainer, because there are actually a lot of conservatives that hate PBMs. There are a lot of big pharma wants us to think that PBMs are the problem. They are a problem, right? They're a source of extraction in the pharmaceutical, I can't even say the supply chain, because they don't touch the drugs. They're not in the supply chain, but in the flow of money through the pharmaceutical market, PBMs are a source of extraction. They are not the biggest one by any means, but it seems to me like a place where you could get political consensus to say, let's just get rid of these, or let's make the state a PBM and not have private pharmacy benefit managers. In any case, I think I was going to make another point and I lost it. I'm sorry. Let's see if others want to jump in there.
Yeah,
and then I can hopefully come back to what I was thinking.
I wanted to just see a show of hands, or if you guys could just look out at the audience, Senator and Ronnie, how many of you have heard of Mark Cuban's pharmaceutical pricing adventure, the online pharmacy cost plus drugs? So look, you know, he's the Shark Tank guy. He's the head. He owns a big basketball team. He's got $1 trillion. But let me tell you why what he's done is relevant to this issue of PBMs. It's not rocket science. There was this guy, Dr. Oshmansky, who is a doctor, who tried to raise money in the nonprofit world to cut out middlemen and basically go to the manufacturer, which, let me tell you, because it gets on to another issue that we'll be talking about. The manufacturer for generic drugs, which is 90% of the prescription fill, is often going to be in India. And basically, if you were to go to India, to go to a company like Cipla or Torrent or Reddy and say, hey, look, we want to buy in volume these prescription drugs at the lowest possible price, and there's no PBM, and they just import the FDA approved drugs, because even though there's a big issue on whether drug importation is legal or not, that's how we get most of our drugs. It's just that big pharma is able to control the distribution, so they can control the price. But long story short, that company has brought a lot of popular attention to the issue of high drug prices to this whole group of people who didn't even know about it until Mark Cuban got involved. And two, he's been able to sell generic drugs, which are supposed to always be cheaper, for like $5 for a month, where they're $100 through their local pharmacy. So that's an example of where, just like Dana says, you get rid of the PBM, prescription drugs are still going to be purchased and sold, and you don't have that problem.
Yeah, and if I can just real quick, thank you so much for that, Gabriel. And it reminded me of something. I think there are just lots of ways that states can help us be creative in thinking about getting around PBMs in different instances. So as Senator Keiser brought up earlier, the state of California is in this moment working on their plans to bring several insulins to market through the public sector, and then later other medications as well. And one of the issues that they're concerned about at the moment is distribution. They want to make sure that when they have those low-cost insulins, that everyone who needs them in California can access them. And they're concerned about the fact that PBMs may not want to put these low-cost insulins on formularies because they don't get the same. The incentive for PBMs is to carry as many of the high-cost drugs as possible and as few of the low-cost drugs because they work on a percentage basis. They take a cut. So the state is concerned that PBMs are not going to put their insulin on formularies, so people aren't going to be able to access it through their insurance. So there's a group of us, some of us technical experts, and then groups of patients who are working with the state, and we're pushing them really hard to look at different options, like just distributing direct to the public. Use supermarkets, use the post office, use community health centers, and distribute directly to consumers. If the price is going to be $30, $35 without insurance, right? Or use that as a threat when you're talking to the PBMs and say, if you're not going to work with us, if you're not all going to carry this, we can either pass legislation that makes it mandatory for retail pharmacies to stock this drug, or you can work with us and put this on your formulary. So I do think, and California is a big state, right? If it were a country, it'd be like the 6th largest economy in the world. So I think when states start to step up and say these things directly to the folks in power in PBMs and insurance companies and whatnot, it does start to change the balance of power. And I really think what California is doing here is going to show us that we can all do more. Not that it's easy, right? But if we all band together, we can start to chip away.
So I have to jump in and put a little reality spin into this, because you're absolutely right, Dana and Gabriel. These all are doable, but we have some political realities we have to deal with. One is rebates. There is this scheme afoot where the manufacturers offer deep discount rebates, and we're not clear because the PBMs have a black box and don't have any transparency where that rebate money is going, but we think that they're capturing a whole lot of it for themselves. Then they convince their customers, who are in the main the big employers, the Boeings of the world, the Weyerhausers of the world, the very large employers use these PBMs because they're convinced it gets them cheaper drug prices. And that's the pitch the PBMs sell them for. The Taft-Hartley Trust for the unions, same problem. So the PBMs have completely captured most of what are called ERISA plans. And those are the ones that are involved with employment. And we have in the state very little authority, virtually none, over ERISA plans, which is one of the other federal problems, which is they don't know about setting floors. They just do exemptions, and you can't do anything. We could have, if we had, a floor minimum for ERISA plans, we could do better. But no, that's not going to happen. Anyway, PBMs are a complete abomination, and you're exactly right. To try and just get rid of them totally would be my preference. But the fact is, the powers that be, and in this state, you have to pay attention when Boeing talks or when the Taft-Hartleys talk or any of the other big players. We have to accommodate their concerns that they'll have to pay more without PBMs.
And they won't.
But we have to make that a guarantee somehow, so they will go with us. And we don't have that figured out yet.
Well, thanks for bringing us home. That's really the bottom line. There are some barriers that we really need your help to overcome. We're doing things in Washington. We're doing things in the other Washington. There are bills to address each of these areas. We need to learn more about it. And I really appreciate Gabe and Dana for joining us, and Senator Keiser. please, please follow the work that we're doing to overcome some of these barriers that have been put in our way. So
Can you please tell us again what PBM stands for?
Pharmacy benefit managers.
So it's not an insurance company, it's a non-transparent, non-controlled, and we need to do that. David.
Hold on. Microphone. Thank you. I seem to remember 3 or 4 years ago, or maybe more, that the Washington State Legislature wrestled with the possibility of people importing drugs from Canada. And maybe you could talk about that. And I don't think the Health and Human Service, the Health Committee and the controlled by Democrats got behind that. Am I wrong?
Well, we certainly looked at proposals and had hearings on the proposal bill. And we kind of got stymied because we had folks from Canada tell us, don't do this or you'll take all our drugs away from us, because they were concerned they wouldn't have a large enough supply to provide the same drugs to the lower 48. So that's where we.
Was it legal? Was it legal if you could get a friend up there to buy it and send it to you?
It is currently legal now. You can go up to Canada with prescription and get drugs. You can go to Mexico and get drugs, but it's on an individual basis. To have it done in a institutional state level, that's another issue.
I would love to be able to chime in on this. I don't know how many people are out there, but I'm very curious to know, by a show of hands, and again, the senator and Ronnie and others can tell me, how many people have a friend or know someone who has imported a drug from Canada or from another country, like my parents? I mean, so let me tell you something. It's technically illegal, but then again, there's many loopholes within the law, just like the senator said, for personal use. So how effective can it possibly be if it's a personal use thing, if it's like FDA's enforcement discretion policy? But look, we like don't have much time, but I have your ear. I have some policymakers' ears. And about 2.3 million Americans each year import a drug, and this is a Journal of American Medical Association study from 2020. They looked at the National Health Institute survey, which happens every 2 years. It's 1.4% of the adult population that buys prescription drugs. And the fact is that Big Pharma 20 years ago hired public relations company Edelman to build a scare campaign, and it worked for 20 years. And people who have been in this business of fighting Big Pharma know that other people don't know all of the details unless they've swam in it themselves. I've been the one swimming in this. And I want to speak to just two things because we don't have much time. I understand that people came down from Canada to speak to the great state of Washington to say, don't take our drugs away. I don't know who funded them, but let me tell you, pharma's one good point, and I've been better at listening to what they're saying to craft our own arguments, but also because sometimes they make good points. I mean, it's true. Canada has 38 million people. We have 330 million people. And so to do wholesale importation, if Texas now, Florida, the three New England states, Colorado, it's actually true. They don't have enough of a drug supply, and the market would not be able to shift fast enough. As Ronnie knows, I did co-found a company called Pharmacy Checker 20 years ago. I went back to law school. I went back to school as a middle-aged law student, and I'm publishing a journal. I'm publishing an article in the Brooklyn Journal of International Law. No more excuses on drug importation, because we need to reform the laws. We need to work with Senator Sanders and others in the Republican Party who would actually do this, to expand the Food, Drug, and Cosmetic Act to include the European Union, which with the UK has over 500 million people, much lower cost drugs, and the drug supply chain is safer. So our gold standard, they have a platinum standard. It's a long story. And last thought, Section 804, that is the basis for these state wholesale importation programs, has 3 subsections, J1, J2, and J3, which give the secretary immense power. And this gets to the question that was asked. Gives the secretary immense power to expressly permit personal drug importation, in which case payers would be able to use it, not just on an individual level, but use through their insurance. And then just to come full circle for the healthcare for all vibe here, people will always slip through the cracks of our broken healthcare system. Personal importation is one way. We got to get it regulated. And it's one way to actually give them a lifeline of affordable drugs from the UK and Canada, which have just as safe prescription drugs as we have here.
Thank you. So we're going to move on to the next stage. Any closing comments about your book? You will be over on the side here to talk to Senator Keiser. I'm sure there are a lot of questions, but if you can add that to the chat, we will pick up the questions and send us an email to talk about more of them. So thanks. Thank you, Senator Keiser. Thank you, Dana, Gabriel, for joining us today.
And thank you very much for bringing us together.
Thank you so much. Great to be with you guys.
So let's bring up Peter Lucas, who is hanging out in Maine, and Cello Echeverria, who will give us a little interlude, a little song and dance.
Yes, I get to be the goofy, silly one. Can everybody see this? Dee, 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 dee. Peter?
Yeah, well, of course, in my hotel room, I can't demonstrate anything. And we're going to introduce our lobbyist, Lonnie Johns-Brown, and she's going to talk to you about what she's been up to. We're very privileged to have her as our year-round lobbyist, and she came to us a little over a year ago. And she's toiled for many years in Olympia, advocating for the citizens of Washington. And before and during the 2023 session, she was a strong advocate for legislation that we helped craft and supported. And she'll now tell you about what we accomplished in past sessions and our plans for the 2024 session. And I think you'll see from what she has to say that she does great work, and she does require a salary, or she requires financial support. So I think after you hear about what she's doing, you'll realize that donating to healthcare for all is really worthwhile, because you'll help keep her in Olympia doing the good work. So Lonnie, you want to take it away? And Charlotte, anything else you want to say at this point?
Modeling the swag.
And there should be links. I hope the links have gotten into the chat for the donations. There's a regular donate button. There's also one for swag. Are those in the chat right now? Do we know?
Great. So is this, can folks hear me if I'm talking into this? Oh, excellent. I always kind of like to use that mic and then so I can feel like I'm a lounge singer or something. But at my age now, I really need to have my notes. So I'm happy to have the lectern. So it's great to be with you here today. I hope that you will all give yourselves a pat on the back, because you continue to move the discussion forward in our state on universal health care and a single payer system. And you are the most organized and effective voice for that cause. We have a lot of allies, but you are the leaders on this. So thank you for that. And it's my privilege to be a part of that. We have big things that we need to accomplish to get to that end goal, right? It's not a, hey, legislature, just take this vote and suddenly we'll have universal health care and single payer. We have these little congressional problems. We have a Medicare, we have ERISA, we have campus, I don't know what else we've got to figure out. You all helped put in place the Universal Health Care Commission. So that's a vehicle for our work. We have the Financial, Technical, and Advisory Committee for the Healthcare Commission. We have a member on that committee. But we have to figure out ways to start moving our state forward. And there's several ways that, a little closer. Locally, I can move the mic closer. Is that better for folks in the back? Oh, thank you. Thank you, Ronnie. So what we focused on this last year was frankly giving the Universal Healthcare Commission the tools to let them do more work. Frankly, because currently they're meeting, the UHCC is meeting every other month, and the FTAC is meeting on the opposite every other month. They got a lot on their plates to only be talking to each other every other month. So what we accomplished with the help of Senator Keiser, by the way, so you can thank her for this among everything else we're thanking her for, she put in, it's called a proviso, request for money, to dedicate staff and expand staff for the Universal Healthcare Commission to the tune of about $2.5 million. And we successfully kept that in the budget. And now we're in the interesting negotiations with the Healthcare Authority about how best to use that money, which really is supposed to go for staff. So we got a little step last week, which is instead of meeting for 2 hours every other month and mostly hearing presentations, the commission will now have an extra hour for every meeting to actually ask questions, discuss among themselves the information they've heard, and perhaps even make some decisions, which would be great. We're actually not quite done with this because we really feel like we gave them enough staff to actually meet for an hour more and then expand how often they meet. So every 6 weeks instead of every 8 weeks. I know this sounds like small stuff, but if we don't get the nuts and bolts to work properly, how are we going to move the policy through this body that we helped create? So we're working with Senator Keiser and Senator Randall and some other folks to put some pressure on the Healthcare Authority to actually tell us exactly where our money went and make sure that if they need more money for more staff, we'll go get it. So, but first we have to find out what they're doing. So that was something that we did to improve the process that we're trying to work within. This next year, we want to work on expanding the way and changing the way we do healthcare in our state. So we're teeing up 3 different, again, they're budget provisos, because frankly, in a 60-day session, they're easier than running bills. And one of them is to go back to the healthcare programs that our state employees and our teachers receive. They're called SEB and PEB. And we want to figure out what would it cost for them to engage in consolidated purchasing so that we could start growing together. The goal here is If we can get 7 PEB together and make them look pretty uniform, can we get the rest of the state-run healthcare programs to be on that same level in a kind of consolidation? A state that can make that happen is a state that can be positioned to go back to the feds and say, you know what? Look what we can do with our own state healthcare programs. Look what we've done. Give us the right to experiment with Medicare. Give us that power. So that's a step that we're going to take. And it's a kind of a controversial step, but I think when we're talking about consolidated purchasing, we're not really getting in the way of the things that unions like to negotiate for their members. We are also going to take a look at a program our state has that helps seniors who are on Medicare or other folks with disabilities who are low income. We actually have, as do many other states, about 20 other states, a program that lets the state Medicaid program in a way supplement that Medicare payment, which is a pretty nice thing when you consider that there's a lot of things that Medicare still doesn't cover. So our state only offers this program up to about 70% of the federal poverty level. Other states have gone up higher to like 100% or higher. So it's pretty, they did a study, they know what it costs to go all the way up to 138%, but they don't know what it costs to go to, well, 90 or 100 or, you know, some more incremental step. So we have sponsors willing to do that for us this year. It's a small study, but they are already talking about coming back in the 2025 session to do that actual expansion once they know those numbers. So that's, again, here we are growing some programs together and also increasing healthcare and access to healthcare for folks in our state. And the last thing is a really important one, and I think you've all heard the phrase Medicaid unwinding. During COVID, all the states, most of the states got permission to expand income eligibility for Medicaid, and our state took great advantage of it. But unfortunately, that crisis is deemed over, and that expansion and expanded share of federal payments for Medicaid for some of these upper levels has gone away. And what we found was that if you are on Medicaid and you for somehow get fouled up and you get dropped off, but you're still eligible for Medicaid, we have a system in place that helps you get right back on pretty easily. But if you don't qualify for Medicaid anymore, but you could qualify for one of the other state programs that we have at different income levels, we don't have a way to get you into that very easily. You kind of have to find it. We don't come find you. We don't give you a notice or any of those things. So our last piece that we're pursuing in terms of this budget process is to say, hey, California just did this. How did they do it? How could we do it? And again, there's a lot of interest in this because we now, our uninsured rate is going up, and that's not good for any of us. So I'm very excited to tell you that for all 3 of these proposals, we have legislators who are interested in helping us, and so we can definitely move forward with that. The last thing I want to mention is a bill, and because we were talking about pharmacy pricing and particularly pharmacy benefit managers, which I happen to know quite a bit about through my time at the Office of the Insurance Commissioner, because we helped craft the first piece of legislation in our state to have regulatory authority over pharmacy benefit managers. Senator Patty Cooterer, who I will just do a personal commercial here, she's running for insurance commissioner next year, introduced Senate Bill 5213. What they found in the last couple of years is, pharmacy benefit managers, as you've heard, they have a ton of money. And so therefore they have a ton of attorneys. And those attorneys are excellent at looking over state laws and finding ways to get around and challenge state regulations. And unfortunately, that's the case with the bill that we passed in probably 2019, 2018. So this bill takes a look at those holes that were found in our past law and would actually create a new chapter just for pharmacy benefit managers, which makes it clearer and easier to regulate them and make them accountable to us. I think you've heard a lot of good reasons why we should get rid of pharmacy benefit managers, but in the meantime, let's regulate the hell out of them. So I'm hoping that we and Healthcare for All will add that to our agenda. I think it fits in very nicely with the other things that we're doing. So that's where we're headed next year. And of course, we'll be supporting other great legislation. I've enjoyed this first year with all of you. I think we're going great places. There's certainly plenty of work. Am I allowed to see if there are any questions? Okay, great. Are there any questions? No? No, everything. Oh, that's great. Thank you.
And thank you, Lonnie. That was great. We're so appreciative. We're so glad you're with us. And then Chella, you want to come up? There you go. So Chella, maybe you can talk a little bit about why why you're interested in our organization, Healthcare for All, why you think we're doing a good job, and any personal statements you want to make about that.
Yes. I lived for 22 years in Istanbul, Turkey, which does not have a universal healthcare system, but it does have very strict controls on private healthcare industries. And it also does have what could be considered a fairly robust public option. So when I moved here in 2010 to take care of my mother at 90, I think at that point she was 90 years old, maybe? No, 80 something years old. And I was going to graduate school to get a master's in public health, having a career change. It didn't even occur to me to get insurance, health insurance, because I lived in a country where I paid $10 to get an MRI, $10 to get an MRI. My mother's drugs, she was on Aricept, Halidol, and another drug, which I forgot the name of, through the local pharmacy was a total of $27. My allergy pills were $3. So it didn't even occur to me to get health insurance. And here I was blithely going through graduate school, not even thinking that I needed to get health insurance until my sister one day said to me, "What, you don't have health insurance? Oh my God, oh my God." And my mother, in her demented state, said, "Well, why would she think about getting health insurance? She lived in a country that provided it." And that is one of the reasons, that is actually the main reason why I'm so active in Healthcare for All Washington, because healthcare is a right. Healthcare is not a luxury. It's a right.
Thank you, Cello. And I'm fortunate that I don't have a personal story about the deficiencies of our healthcare system, but I've been practicing psychiatry for over 40 years in various settings, much of it in Washington State. And I've observed firsthand the deficiencies and disparities in the national and Washington mental health care systems. There have been way too many times when my patients were not able to receive the care they needed because of lack of insurance or other barriers created by our profit-driven system. And of course, like everything else, minorities and poor folks are especially left out and suffer greatly as a result. And I believe strongly that a single payer system would greatly improve access to mental health care for all segments of our society and improve the overall health and welfare of Washington. I've been on the board of this organization for almost 10 years, and I really have seen firsthand how much our efforts have contributed to meaningful improvements in healthcare in our state. And the work of our dedicated lobbyists, board members, volunteers, and other supporters have been very effective in developing and promoting progressive legislation. In addition, our outreach activities such as in-person presentations, webinars, emails, and social media have done much to raise awareness and inspire other people to inspire others to act. And in addition to the many hours I've spent volunteering for Healthcare for All Washington, I donate on a regular basis to support our lobbying and outreach activities. So that's sort of a segue to this next portion, which is I want you to join me in donating today. And if you are not already, becoming a volunteer. Now, this annual meeting is one of our two major fundraising events. And has been said several times that we are especially encourage and appreciate monthly recurring donations, which provide steady support throughout the year to pay our lobbyist, who you just heard from, and our communications specialist, Sydney, as well as other activities such as we've heard about. And I see it as being like Netflix, but instead of videos, your monthly payment goes to promote health and justice. And to stimulate your generosity, the board members of Healthcare for All Washington have pledged $5,500 out of their own pockets. And I think that really demonstrates our commitment to the mission of Healthcare for All Washington. And let's see if you can match or exceed that total today. Now, I was informed that there may not be links in the chat. Is that the case to make donations? Can somebody confirm that? If that's the case, I'm going to ask you to go to our website, healthcare, it's just HCFA-WA.org, and click on the donate button, and you'll be able to make donations. And there is a swag link, but I don't know if that's in the chat right now. That'd be a link to get the t-shirts and the scarves for your donations. Do we know if that's in the chat?
David Love?
Are there donation
Yes.
envelopes in the room here?
Yes, there are donation envelopes in the room. If everybody who would like to donate can come up to Sid and I, sitting under the Healthcare for All banner on the right-hand side. We can help you with your donation. We accept checks, and we also have linked to our online donation site. The links are also in the chat for both the swag, our lovely swag, and for the donation button on our homepage. And please do consider becoming a monthly member, a monthly donated member. It really helps us with our budget. We are an all volunteer organization. I personally donate about 20 to 22 hours a week on this organization, because that's how much it means to me to get universal health care. The only money that we spend is on our lobbyists and Sid, our wonderful communications person. Thank you, David. David is going around with the envelopes because we obviously don't have everything together here, because we are an all volunteer organization. We are not professional fundraisers. And David? Okay. Peter, did I leave anything out?
I don't think so. And other than if for some reason you can't access the button to get the scarves or the t-shirts, if you make a donation, we will send you an email telling you how you can get your loot.
Can you hear me? Yeah. Please do get a t-shirt or a scarf. I'd like to just tell you one final personal story. We were all out at the Medicare anniversary rally in front of, what was that, on Fifth Avenue, in front of the building there, the federal building. And Ronnie had his Healthcare for All umbrella because it was 80 degrees out and super, super sunny. And 3 legislators walked up to us and started talking to Ronnie because we had our umbrellas. So it does make a difference. It is a conversation starter. I wear mine. I have stickers on my car that I made. You would be surprised how many times people come up to me when I have my little Medicaid for All on my bag saying, "Oh, what's that about?"
Yes. There's a question in the chat about if people cannot come, are not here, but online, can they get a t-shirt by mail? The answer is yes.
Yes, if you donate, and if you can't do it through the links in the chat, we will, every donation from this meeting, we will reach out to you by email and let you know how you can get the merchandise.
Yeah.
And if you make a monthly donation, we'll send you a t-shirt and a scarf.
Thank you, Ronnie. Yeah.
David.
Yeah, I just want to point out, it took me a while to find the little box to check monthly recurring donation on the envelope. It's at the very bottom of the, fold down section that you fill out.
So thank you all for participating or for joining us and for adding those questions to the annual conference.